In this video, we're going to continue with the respiratory system, starting to look at the respiration process. So we have internal and external respiration. Internal respiration, or cellular respiration, looks at the intracellular metabolic processes that go on in the mitochondria. It's using the oxygen to derive energy and then producing carbon dioxide. The respiratory quotient is the ratio of carbon dioxide produced to oxygen consumed. So when carbohydrates are being consumed, the ratio is 1. When fats are being consumed, it's 0.7. When proteins are being consumed, it's 0.8. So external respiration is going to look at the exchange of oxygen and carbon dioxide between the external environment and the lungs. So there's 3 steps to this process. First, air is moved in and out of the lungs. This has to happen for there to be an exchange of the gases between the atmosphere and what's in the alveoli. So this is your ventilation or breathing. Oxygen and carbon dioxide are going to be exchanged between the alveolar air and pulmonary blood, and then that blood gets transported to the rest of the body. So this first step here, you've got the ventilation or gas exchange that's between the atmosphere and the air sacs in the lungs. So carbon dioxide going out, oxygen going in. We have the exchange of the oxygen and carbon dioxide between the air and the alveoli and the lungs. So this is going in and out of the bloodstream here. This blood is going to have to be transported by the heart, and it will go into the systemic circulation that's going to deliver it to the tissues, where you can have the internal respiration. You've got the exchange of oxygen and carbon dioxide between the blood and the actual tissues, and then you have cellular respiration occurring in the cells. This is just another picture that sort of illustrates the point of you've got the gas exchange going on between the atmosphere and the blood in the lungs, and then between the blood and the tissues in the rest of the body. There are some non-respiratory functions that go along with this. It is a way of eliminating some water and some heat elimination. So when the air is inhaled, it's going to be humidified, and then it's warmed up before it's expired. So you'll lose some heat that way. It will enhance venous return. So your respiratory pump is going to help with the muscular contraction that's going to drive blood back into the heart. It's going to help maintain normal acid-base balance by removing carbon dioxide from the expired air. It decreases the amount of carbonic acid in the blood. It allows us to have speech, so it includes singing and other vocalizations, smell, and then it's going to remove, modify, or activate materials that pass through the pulmonary circuit. So this would include inactivation of prostaglandins, and then the activation of angiotensin II by angiotensin converting enzyme. So breathing or pulmonary ventilation is the physical movement of air in and out. This will provide your alveolar ventilation. Air is going to move in and out of the lungs. It's a negative pressure pump mechanism. So the air is going to move from an area of higher pressure on the outside to lower pressure on the inside. And this is created in the thorax using the lungs and the diaphragm. So this model here shows how you have kind of this lollipop area that gets pressed into this balloon, and this balloon around it creates your pleural sac. The lollipop is like your lung. So pressure is going to be inversely related to the volume. So pressure will go down as lung volume goes up. So when pressure goes down, that's going to help to pull air in. Atmospheric pressure is considered 1 atmosphere, or 760 millimeters of mercury. So these pleural membranes are an important part of creating the pressure changes in the lungs. So air moves into the lungs because you have the pressure gradient. And there's different pressures. You've got the atmospheric or barometric pressure. This is caused by the weight of air on the objects on the Earth's surface. So at sea level, it's 760 millimeters of mercury. As you go up in altitude, it's going to decrease. The intra-alveolar or intrapulmonary pressure is the pressure within the alveolus. It's going to be directly connected to the outside through the respiratory tubes. So air moves due to a pressure gradient difference between your intra-alveolar pressure and atmospheric pressure, or IAP and AP. The intrapleural pressure or intrathoracic pressure is the pressure within the pleural sac. This is the pressure exerted outside the lungs within the thoracic cavity. So it is going to be less than the atmospheric pressure. It's 756 millimeters of mercury at rest. So the intrapleural pressure will not equilibrate with the IAP or AP because there's no direct connection with the outer pleural cavity and the inside of the lungs. So this allows you to see here you've got atmospheric pressure, intra-alveolar pressure, and then the intrapleural pressure, the three different places where those pressures are located. So your thoracic cavity is larger than the unstretched lungs, but the two forces hold the lungs and the thoracic wall close together. So when you have stretching the lungs to fill the thoracic cavity. So some things that are going to contribute to this, you've got the intrapleural fluid cohesiveness. Pleural fluid is going to be between the parietal and visceral pleural membranes. The water molecules in there have hydrogen bonding that resist it being pulled apart. So you have this cohesiveness in there in the thin layers of the water-based fluid. So as the thoracic wall expands, the visceral pleura is going to be pulled along with the parietal pleura to expand the volume of the lungs. So then we have the transmural pressure gradient. So your IAP is equilibrated with the atmospheric pressure at 760 millimeters of mercury. But these two pressures are greater than the intrapleural pressure, which is 756. So that gives you a net pressure difference, and we call that the transmural pressure gradient. So during inspiration, the intra-alveolar pressure is lower than atmospheric pressure. During expiration, it's greater. At the ends of both inspiration and expiration, you have the intra-alveolar pressure equal to the atmospheric pressure in a just very temporary time frame in there, because the alveoli are going to be in direct contact or direct communication with the atmosphere and the air. So it's still going to move down the pressure gradient. So that TPG exists along the lung wall. It's an outward force, and across the chest wall, that's going to be an inward force. So this is going to be what prevents the lungs from collapsing. So that TPG is greater pressure that pushes inward on the chest wall, and it also prevents the wall from springing out. This is what helps to hold things in place. So this picture here helps you to be able to see where you have your transmural pressure gradient. So Boyles Law helps to explain a lot of the mechanism of breathing. Boyles Law states that pressure is equal to 1 over volume. So the greater you make the volume, the lower the pressure is. And the flow of the air in and out of the lungs is due to cyclical changes in this pressure. So this can be changed by altering the volume of the lungs. So if you have a closed container, and the size decreases, the pressure inside is going to increase. If the size of the closed container increases, the pressure decreases. So the molecules have less wall area to strike, so the pressure on each inch of area is going to increase. And this is a nice visual of this. If you've got more space, the pressure is lower. If you decrease the space, the pressure is going to be higher. So breathing in requires muscular activity and chest size changes. When you breathe in, you're basically putting it in this position to lower the pressure to pull air in. Contraction of the diaphragm is going to do a lot of this. It's going to flatten the dome and increase the vertical dimension of the chest. So when we look at inspiration, the first step is to expand the lungs, and it involves contraction of the main inspiratory muscle, the diaphragm. Inhalation occurs when the intrapulmonic pressure falls below the atmospheric pressure. This is going to be the result of contracting the diaphragm and the external intercostal muscles. It increases the size of the thorax, decreasing intrapleural pressure so that the lungs expand. So that will decrease the alveolar pressure so that the lungs will fill because the air is going to move along the pressure gradient from the atmosphere to the lungs. So during forced inhalation, you're going to make that cavity even bigger using accessory muscles, the sternocleidomastoid, scalenes, and pectoralis minor. So these muscles of inspiration don't directly act on the lungs, but what they do is they change the volume of the thoracic cavity, and that's going to change the volume of the lungs. So at rest, pressure inside the lungs is equal to pressure outside the lungs. When you inhale, the diaphragm contracts, drops down, rib cage expands, increases the thoracic volume, increases the lung volume, and the IAP drops. Air is going to come in to equalize it. So the diaphragm moves about 1 centimeter, and then the ribs get lifted by the muscles. So the intrathoracic pressure falls, and you can inhale up to 2 to 3 liters. So when we talk about the respiratory cycle, it's going to include 1 inspiration and 1 expiration. So this is showing where the diaphragm is before inspiration and the external intercostal muscles. During inspiration, you can see the diaphragm is going to come down, and the intercostal muscles are moving the rib cage up and out to the side. So quiet inspiration, diaphragm moves about 1 centimeter. And this is showing the difference here with the rib cage. Expiration or exhalation is moving the air out of the lungs. This is going to occur when the alveolar pressure is higher than atmospheric pressure. So when you relax the diaphragm and the external intercostal muscles, there's the elastic recoil of the chest wall and lungs. This increases the interpleural pressure, decreasing the lung volume and increasing the alveolar pressure. So the air is going to move out of the lungs into the atmosphere. So there's also an inward pull of surface tension due to the film of the alveolar fluid. So exhalation does become active during labored breathing when the air moving out of the lungs is impeded. Then you can employ forced expiration, and you'll use the intercostal muscles and abdominal muscles to help with that process. So for quiet expiration, it's a passive process. There's no muscle action. It's just the elastic recoil going back to their normal place. The alveolar pressure will increase and push the air out. So your intrathoracic pressure, it's always subatmospheric at 756 millimeters of mercury. This is comparing at sea level. But when the diaphragm contracts, the pressure will decrease even more, down to 754. So this helps keep the parietal and visceral pleura sticking together. So this is showing here your alveolar pressure at rest at 760, the intrapleural pressure 756. During inspiration, you're lowering that alveolar pressure. You decrease the intrapleural pressure. It's going to pull air in. During expiration, diaphragm goes back up. Your intrapleural pressure stays lower, but your alveolar pressure is going to increase. That's going to push air out. So that alveolar pressure is going to be a lot of what determines what gets pulled in, when you're pulling in and when you're pushing air out. This just gives you a comparison of the pressure versus time. So when alveolar pressure decreases, air rushes in. Alveolar pressure increases, air rushes out. That's the key summary of it. And this is another picture here. This just incorporates pictures of the lungs showing the pressure going up and down to pull air in and out. So with labored breathing, this is your forced inspiration and expiration. For forced expiration, the abdominal muscles are going to help force the diaphragm up. So when the abdominal muscles contract, the space where all those abdominal organs are is decreased, and it's going to push some of them up against the diaphragm. Your internal intercostals will depress the ribs. During forced inspiration, the sternocleidomastoids, scalenes, and pectoralis are going to lift the chest upwards and help you pull more air in when you're gasping for air. So this is showing here the SCM and the scalenes, the actions of those, the external intercostals, pulling the rib cage up and out. Here showing the internal intercostals pulling it down, the abdominal muscles contracting, the external obliques of the abdomen contracting as well. So the compliance is how much effort is required to stretch or distend the lungs. It's how hard you have to work to blow up the balloon. It will measure how much change in the lung volume results from given change in the transmural pressure gradient. So the less compliant the lung, the higher the transmural pressure gradient has to be to stretch it to produce a normal lung volume during inspiration. So a great transmural pressure gradient can only be accomplished by decreasing the IP below its normal subatmospheric level. So this requires greater expansion of the thorax and a more vigorous contraction of the inspiratory muscles. So this will depend on the elasticity of the lungs as well as the surface tension. So there are some diseases that will reduce the compliance. So you can have scar tissue from TB infection, pulmonary edema where you have fluid in the lungs and reduced surfactant, paralysis can also influence that. So airway resistance, this is the resistance to airflow. It depends on the airway size. If you increase the size of the chest, the airways increase in diameter. You contract smooth muscle in the airways, it will decrease the diameter. So the primary determinant for airflow, just like blood flow, is vessel resistance. So in a normal individual, they have large enough bronchial tubes so that negligible resistance is contributed. But the vessel diameter can be dramatically influenced by contraction or relaxation of the smooth muscle layer within the bronchial tubes. So those bronchial smooth muscles, they're sensitive to changes in the local environment, things like carbon dioxide. So if the alveolus is receiving too little airflow, carbon dioxide will increase in the alveolus as it fails to be exhaled properly. Carbon dioxide can promote relaxation of the smooth muscle and increase the diameter and decrease resistance. So airflow can now match the blood supply. The blood flow to the alveolus has to be carefully controlled. You do this by adjusting the resistance of the blood vessels. So if blood flow is too high, you have increased diffusion of oxygen into the blood, and the blood oxygen levels in the alveolus and surrounding tissues drop, causing vasoconstriction in pulmonary arterioles to constrict. If airflow is too high, it's going to increase the oxygen levels in the alveolus, and you'll have vasodilation to increase the blood flow. So this gives you a nice little comparison of bronchoconstriction and bronchodilation, things that can cause it and what's actually happening to the resistance. So bronchoconstriction, you increase the resistance. bronchodilation, you decrease the resistance. So we can have some altered breathing patterns. Eupnea is the normal variation in breathing rate and depth. Apnea refers to holding the breath. Dyspnea is painful or difficulty breathing. Tachypnea is rapid breathing. When you have costal or shallow breathing, this is, think rib cage. This requires combinations of various intercostal muscles. This is usually needed to increase ventilation with exercise. Diaphragmatic breathing or deep breathing. This is going to be, you move air by contracting and relaxing the diaphragm to change the lung volume. So it goes more into the abdomen because that will allow more movement of the diaphragm. And then we can have other modified respiratory movements. They can be used to express emotions, clear the airways, coughs, hiccups, things like that. So the respiratory rate and volume, it's going to adapt to the changing oxygen levels. So you can change the number of breaths per minute, which would be your respiratory rate, the volume of air moved per breath, which would be your tidal volume. So the respiratory minute volume is how much air is moved per minute. You just multiply the respiratory rate times the tidal volume. It's very similar to measuring cardiac output. So that's your pulmonary ventilation. Your anatomic dead space, this is only a part of the respiratory minute volume that reaches the alveolar exchange surface. So the volume of air that remains in the conducting passages is considered anatomic dead space. With alveolar ventilation, that's the amount of atmospheric pressure that is exchanged between the atmosphere and the alveoli in a minute. So deep, slow breathing can increase alveolar ventilation. Shallow, rapid breathing can eliminate alveolar ventilation. So spirometry is a way of measuring the primary lung volumes. So we can look at the non-overlapping components of the total lung capacity. So these are the individual components in here. So the tidal volume is the volume of air that goes in and out of the lungs in a single normal unforced breath. So on this chart here, it's this small little bit here. Your inspiratory reserve volume is the additional volume of air that you can take in after the tidal volume. So if you've taken a normal breath, here is your tidal volume. It's how much more you could take in beyond that normal breath. The expiratory reserve volume is the added amount of air that you could expire beyond the tidal volume. So after you've done your normal exhale, how much additional can you push out of there? And then the residual volume, this is what's left in the lungs after you forcefully exhale out as much air as you can. So lung capacities, these are going to be the sum of two or more volumes. So total lung capacity is the sum of all four lung volumes. So it's your residual volume, expiratory volume, the tidal volume, and the inspiratory volume. Your vital capacity is the amount of air that can move in and out of the lungs after you inhale as deeply as possible and exhale as deeply as possible. So this is going to be the tidal volume plus the inspiratory reserve volume and your expiratory reserve volume. So inspiratory reserve, tidal volume, expiratory reserve, adding all three of those up. So we can have some airflow disorders. So restrictive disorders are conditions where the vital capacity is abnormally low. Pulmonary fibrosis because of the reduced compliance. Emphysema, the walls of the alveoli are destroyed. With obstructive disorders, you have obstruction of the pulmonary air passages. It makes it more difficult for the air to flow through. So bronchitis, you can have inflammation, edema, asthma that somehow restrict what can go through the passages. So things can be abnormally low for forced expiratory volume. So the percentage of vital capacity that can be forcibly expired in a specific number of seconds can be looked at. So with COPD, chronic obstructive pulmonary diseases, these are ones that are going to affect both obstructive and restrictive airflow. So Dalton's law is going to look at the exchange of oxygen and carbon dioxide. So now we're moving into looking at what is going on between the blood and the tissues. And we're going to put that in a separate video since this is getting to be quite a long section.